right? And so I guess, where do you see, I mean, because we exchanged a couple of emails and you were saying, where do you see right now in suicide prevention where you think some of the maybe professional guidance might be um, a little bit off, or where would you change some of the protocols in practice?
Yeah. So first thing is to move away from risk prediction or risk assessment with the goal of predictions. That's the first thing I would do. Is you have to move away from that. And just another point on that. So it's not just that it's clinically unhelpful; it is often clinically harmful, because what you have is you have these therapists who are trained to do this assessment. Actually, let me take the client's perspective, right? So you have a client who they're feeling terrible, they're in tremendous pain, psychological pain, and they're considering killing themselves. So they make an appointment with their therapist. So they go to see their therapist, who they've been working with for a while, and what the therapist does is the therapist digs into their desk, they find a form, which is a suicide risk assessment form, and they focus on asking them these questions on this form that they sort of stumble through. And this is sort of weird for the client, as the client's been working with this therapist for the last couple of months. And other than a little bit of the first session with this therapist, the therapist hasn't used a form, right? The therapist has been there with the client. And so the therapist sort of is using this form and asking these really prescribed questions in this really prescribed sort of way. And then from the therapist's perspective, the therapist is also now feeling this anxiety, because the therapist is thinking, oh shit, do I have to hospitalize this person? And if I hospitalize this person, I have to pick up my daughter at daycare at 5. It's 3:45 right now. If I have to hospitalize them, and if I call an ambulance, or if they go, do I feel safe to? And then, well, maybe I could get my mother-in-law to go pick Julie up at daycare. But oh wait, I think my mother-in-law, I think she has right. So like this is
Right.
happening within the therapy. Like, I sort of come at it a little bit from the therapist perspective, having been in that seat. And it's like, you realize it's self-evident. I am not the good therapist that I typically am. Like, I'm just not. And we train therapists oftentimes in ways that inhibit their ability to be good therapists when they're working with suicidal clients, because they're focusing on all this other stuff. And then the client who's in the other side is all of a sudden going, why the hell is my therapist? And then they realize, oh yeah, my therapist isn't actually going to help me very much with the pain that I'm going through right now. Right. So they withdraw. So like that is a real problem. So it's not just that the risk assessment stuff is not clinically beneficial. It's all these unintended consequences. Now, if we take that one step further, which is so if a person is high risk, even though, as I've said, it's clinically useless, that we hospitalize them, what's jarring is that there is no compelling evidence that hospitalization actually keeps people from dying by suicide.
Really?
Yeah. So lots of people. So when I was in graduate school, the first time I worked in a psychiatric hospital, we had somebody die by suicide in the hospital.
Okay.
So people die by suicide in hospital all the time. And then also, quickly upon release from hospital, there's this huge uptick in suicide. So for some folks, it seems that, yeah, we might put it off for a week. But what does that do? Like, what's the benefit of that, right? And we also see that in hospital, there's all these negative consequences to hospitalization, right? So, I mean, imagine if you're hospitalized, then you can't take care of your dependents. You can't you can't be at your job doing the stuff you need to do for your job or for your schooling. And now all of a sudden you need to figure out, do I fail the classes? Do I see if I can get a hold so I can retake this next semester? Do I do right? So there's also this jarring amount of post-traumatic stress that, not always, but a surprising number of time. There's different studies done on this, and I've seen from a low of 20% to a high of 45% of patients who are hospitalized for suicide end up with hospitalization related post-traumatic stress symptoms.
Wow.
So yeah. And if you've ever been in a psychiatric hospital, I mean, obviously there's lots of between hospital variability, but some of those people in psychiatric, some of the patients in psychiatric hospitals are kind of scary.
Right.
And so you're a person who's really depressed and suicidal, so you get hospitalized, and you're sharing a room or in a shared space with somebody who's twice the size of you, who's, experiencing, a psychotic episode where they're talking to people that aren't there and doing really weird things. Like, it's scary. It can be
Right.
scary.
And then someone that who doesn't have that level of I guess mental challenges or dysfunction, however
Right.
you want to call it, then they're in this hospital and they're thinking, "Oh shit, this is who I am now."